So for the next talk, we'll talk about multi-ligament knee injuries. And, just to be clear, no financial disclosures related to this. And then I've set this up just as like 4 cases. So we'll go through those and hopefully we can make it interactive and I think some really interesting cases, and then we can focus on reconstruction techniques and indications. So first case, this is a 30-year-old. He had a left knee injury. His dog ran into the street. He chased after the dog, and then he was hit by a car on the lateral side of the knee. He presented to the general hospital, had a neurovascular injury to his hand that required surgery, and then was also instructed to follow up for his knee. I saw him about a week after. Range of motion was like 0 to 80 degrees, had a 2B Lockman, had grade 3 opening to valgus stress, including in full extension, stable to varus, and negative posterior drawer. So here are MRI or MR images for him. He had a complete ACL tear. And then, let's see, Monica, thoughts on his, so on the coronal T2, thoughts on the MCL?
There's a lot of edema over the MCL, and I think that it looks like there's a tear as well.
Yeah, and where would you say it's torn?
Sorry, I'm just looking. Looks distal.
Yeah, exactly. So kind of a distal MCL avulsion. I think, things to talk about are surgery versus non-surgical treatment, timing of surgery, graft choices, and techniques. With this first one, I know you had ACL before, but so we'll, first case, we'll focus more on like the MCL especially. And this type of picture will pop up on tests. So would definitely, try to remember these relationships. I think especially like the MPFL in its relationship with the adductor tubercle medial epicondyle, and then the MCL. Obviously have the superficial and the deep components. And then the things to remember with the MCL. So you have your the femoral sided origin of the ligament, and then have the meniscotibial ligament attaching close to the joint line. And then the footprint of the proximal aspect of the superficial MCL. And then that distal attachment is really like 6 centimeters distal to the joint line. So it really attaches pretty far down below the pes tendons. All right. When we have MCL injuries, and we commonly see the combined ACL, MCL, and the MCL sprains have excellent healing potential with bracing. And so our primary treatment for grade 1, grade 2 injuries is bracing for MCL healing, and then followed by staged ACL reconstruction. With this, you want to make sure that you're doing a good EUA at the time of the ACL reconstruction. And if there is no valgus instability, if that MCL is healed fully, then no surgical treatments needed for the MCL. But if there is instability to valgus stress, then you do need to address the MCL at the same time, because failure to address the MCL increases your risk of ACL graft re-tear. And this can be, in a lower grade injury, grade 1 sprain, maybe that everything feels solid, feels like the other knee. If there's any question, wouldn't hesitate to do a stress fluoro exam to really, gauge the opening of the medial joint space under valgus stress, and then compare that to the contralateral knee. That can give you kind of an objective measurement.
Are you typically waiting like a full 6 weeks then before you bring them for their ACL surgery?
Yeah, generally like 4 to 6 weeks, and with like a really low grade sprain, won't impact things as much. But you're looking for both restoration of motion and healing of the MCL. The knee can get stiff with the MCL sprain. It's really getting those people into rehab, getting the knee moving, And then once they have motion and the MCL feels fine, but usually around like 6 weeks is pretty safe number.
Got it.
And then, so when you have a grade 3 injury, it's a bit more controversial. Does anyone know an absolute indication for MCL surgery?
Like a Stenner lesion of the distal MCL.
So I agree with that, and that's probably more in our relative even, but the best absolute indication is if the MCL is incarcerated in the joint. So sometimes it can avulse and then flip up into the joint. And that's absolutely 100% has to be addressed. Otherwise it's in the joint. And then like Erica said, so you can get a possible Stenner lesion at the distal MCL, and tibial sided avulsions in general have a lower healing rate. And so that can be, a good indication for, being more aggressive and fixing the MCL. And then the femoral sided or mid substance grade 3 injury that may heal with bracing. There is better healing potential. So that can be, brace them, see how the knee feels over time, and then address if needed at the time of ACL reconstruction. And then with this, I'd say my preference, so if it's a distal avulsion, I'll favor either surgical repair plus or minus augmentation reconstruction based on the tissue quality. And then if it's a femoral sided injury or mid substance, would attempt bracing and then with treatment if needed at the time of eventual ACL reconstruction. And then we'll do the good EUA in both full extension and at 30 degrees of flexion. If they open in full extension, would definitely plan to treat the MCL. And then, get stress fluoroscopy if any question. I think sometimes it can be like, okay, I might feel a little different than the other side, and would, stress the joint. And then, you can, know how much the joint will gap with these various structures. But really, if you're comparing side to side and there's notable difference, then may need to reconstruct or repair that ligament. So surgical techniques for the MCL are there's so many described. This was a systematic review a few years ago where they summarized a number of these different techniques for both repair, an augmented repair, and reconstruction. And from those results, there's no clearly superior technique. Their conclusion was that further studies are needed. But the MCL, in contrast to like an ACL injury, like you can repair the MCL and get good results. So if the tissue quality is good, that can be an option. In the more chronic setting, you may need, to reconstruct both the superficial MCL as well as the posterior oblique ligament. That's kind of our, the far other end of the spectrum. So depending on tissue quality, that will really make your determination of best approach. Another good way to treat the MCL can be with using the hamstring tendons. You can use them attached distally and then bring those up to the isometric MCL point and then fix them distally again. So that'll use local autograft. You keep that insertion intact and then can provide augmentation to any attempted repair with that. There is also current interest with using even like suture augmentation, so like an internal brace, and using that to provide stability for the MCL as well. All right, so back to our case.
About the internal brace, Dr. Lansdown.
What's that?
Can I ask a question about the internal brace?
Of course.
All the other repair or reconstructive techniques use a tissue that has some compliance to it. What's your thought? And the femoral condyle is obviously not as a cam, right? So the distance has to change some. What's your thought on the internal brace and like being able to get a true isometric point with a non-round femoral condyle?
Yeah, I agree with that thinking. And I personally don't use it. Like, I think that using like hamstrings is better for that reason. Mm-hmm. But it's definitely, it's done. It's like, there are results on it. And, it may be that, it's just like a, almost like a check rein or, just preventing excessive instability
Okay.
and protecting the repair. But yeah, I think I agree for that reason. All right, so Eric, what would you do in this case?
Given that there's a tibial avulsion, I would. Sorry, I'm eating breakfast.
No problem.
I would also. I would plan on probably doing a reconstruction, because I think it'd be hard to. You could use a suture anchor, I guess, to tack down the distal MCL, but I would definitely address the MCL in some way, and then do an ACL as well.
Yeah. So he's gapping in full extension. He has no endpoint on valgus stress. And I agree. And that distal MCL, if you do that acutely, it can be like really stout tissue that you can get a good repair with. And had planned for early surgery, but in his workup was found that he had Wolff Parkinson's White. And so surgery was delayed as he had cardiac workup, et cetera. And then, so now it's 6 weeks from injury. Any change in plans?
I mean, you could re-examine him and see maybe he did heal, and if he went from a one that has no restraint to now having restraint, then potentially you don't have to address it. But
yeah, and so he's the same.
Yeah, then I would still probably wouldn't be able to do the repair anymore, but I'd probably maybe you did augmented.
Yeah, and so his tissue quality wasn't great. So I attempted to repair the MCL that was there, and then use that hamstring autograft augmentation. So that's just a spiked washer with a screw at the medial epicondyle. And so the hamstrings are left attached distally, looped around, and then fixed on the tibia. And then this is fixation of the distal superficial MCL here. But that will give that repair plus some augmentation because of that kind of questionable tissue quality. And then the BTB ACL. So in general, when there's an MCL injury, I personally don't like to use hamstring tendons just because they can give some medial support.
Mm-hmm.
And if you're concerned about the medial side of the knee, I won't take those for the ACL. And then here, obviously use them for that. But if even in a healed MCL, I'll kind of lean away from hamstrings if there's any concern. That one's not as well based in evidence, but seems to make sense. All right. Any questions on that one before we move on? All right. So number 2, this is a 28-year-old man, had a right knee injury from a motorcycle accident 3 months before presentation. He flew 20 feet, unconscious at the scene, hospitalized for 3 weeks, and then had continued pain and instability in his right knee. He had initially had difficulty with dorsiflexion, and then improving foot function over time. And then when he presented 3 months after, had an antalgic gait, 5 to 120 on motion, 2B Lockman, grade 3 varus, and no endpoint in full extension or at 30 degrees, negative posterior drawer, and then a positive dial at 30 degrees. So Sashin.
Oh my gosh.
Yeah, I mean, so just looking at this, oh, okay, never mind.
Yeah, well, what are you thinking?
Well, so he's got clearly has an ACL tear based on that physical exam. His ACL is torn. PCL is reassuring that there was no posterior drawer, as well as the dial test being negative at 90 degrees. If his dial test is only positive at 30 degrees, so that's consistent with posterological corner injury, likely without PCL injury. So I'm already thinking about looking for those 2 sort of areas on the MRI.
All right. So what do you see? What do you see through here?
So yeah, just in the notch, the ACL is torn. On the lateral side, it's possibly an LCL injury. It's hard to, yeah.
Yeah, and so Just coming back.
There's certainly like a posterolateral corner injury. I think this is LCL.
Yeah, this is kind of stump of LCL.
Yeah.
And then there's nothing tracking, and then this is popliteus, and you have just kind of a wavy tendon that is also not attached. Yeah, I think so. Clear disruption of posterolateral corner and ACL. All right. Oops. All right. So posterolateral corner, we know, is comprised of the fibular collateral ligament or lateral collateral ligament, popliteus, popliteofibular ligament, and then you have, the IT band, lateral gastroc, biceps tendon, but these relationships, especially, like, those will show up on tests, and then really when you're treating these patients, that this anatomy is very relevant in the operating room as well, to be able to reconstruct everything appropriately. And then, so the LCL originates proximal and posterior to the lateral epicondyle. So you should be able to find the lateral epicondyle, and then the LCL will be just slightly proximal and slightly posterior to it. And then the popliteus tendon attachment is 18.5 millimeters proximal and posterior. Or sorry, the LCL is 18.5 millimeters proximal and posterior to the popliteus. So popliteus here, and then we go proximal, posterior, and that's the LCL. And then the LCL inserts on the lateral aspect of the fibular head, and about 1/3 from A to P. So this is our most anterior structure on the fibular head, and it's 8 millimeters posterior to the anterior aspect of the fibula. And then from the fibular styloid, about 28 millimeters distal. So it's not like up on the tip, but kind of on the side right here. And in doing these reconstructions, I think Sasha and I did one posterolateral corner reconstruction, but when you're doing these, like, you really are measuring these areas to make sure you're in that right spot to recreate the anatomy that's disrupted. And then, so the popliteus tendon, you have the proximal attachment at the popliteal sulcus at this anterior aspect of the lateral femoral condyle, and then a broad attachment on the posterior aspect of the tibia. And then the popliteofibular ligament is very important for posterolateral corner function. And then this is on the fibular head, just distal to the styloid, and connecting fibula to that popliteal tendon at the musculotendinous junction. And then with these injuries, you can see avulsions of the IT band, avulsions of the biceps, injuries to the lateral gastroc, perineal nerve. So really looking at these structures on your imaging is important as well. So with posterolateral corner injuries, these are uncommon. And this is one series, 330 patients, acute knee injury. 9% of patients had an injury to the posterolateral corner. And then 2% had an isolated injury to the posterolateral corner. And then in another study from Laprade, 5% for urgent evaluation had a posterolateral corner injury. So this is not going to be one of the more common things we see, but it is really important that you don't miss it, because you may undertreat other issues if overlooking this. And then it's most commonly seen, as seen here, as part of a multi-ligament knee injury rather than just an isolated injury. And then important to keep in mind that about 1/4 of these injuries will have a perineal nerve injury. We will see these generally with higher energy trauma. So this patient, a motorcycle accident, but car accidents, contact injury with sports, can be a direct blow to the anterior medial tibia, or hyperextension and varus force. And then I think, with that nerve injury, it's important to kind of realize when you'll see those. So if you have a distal avulsion or a fibular head fracture, they had a displaced perineal nerve. And then if it's a proximal injury, that nerve was not displaced in any of those patients. And so our first step surgically with these patients is finding the nerve. You can generally follow it on your MRI and know where it will be. But especially if you're seeing a distal avulsion, especially if the biceps tendon is off and retracted, that perineal nerve may not be in its usual location just behind the biceps. So as you're doing your dissection, you want to prepare for where it might be so you don't cause a nerve injury. All right, and then the exam for posterolateral corner, so we'll check varus stress at 0 and 30 degrees. And this is really checking the function of the LCL or FCL. And then we'll grade this 1, 2, 3. And the dial test, with this, we'll have the patient prone, check at 30 degrees and 90 degrees of flexion. So like Sachin said earlier, that 90 degrees is looking for combined PCL injury. And then more than 10 degrees of external rotation is indicative of a positive test. Have a couple of classifications. In general, these are more, I think, used in research purposes, but it's kind of helpful to frame how you're thinking about them also. So grade 1 for the Houston classification is 0 to 5 millimeters of opening or 0 to 5 degrees, and then 5 to 10 or 6 to 10 degrees, and then greater than 10 millimeters or 10 degrees with a soft endpoint. And then usually that grade 3 injury we'll see with an associated cruciate ligament injury. And then the Finelli-Larson classification is just factoring in the rotational component also. And then on X-ray, you can see, fibular head avulsion. So always, be mindful of that. And, these injuries are usually best treated with direct repair. All right. And then, similar to our MCL, you can use stress X-rays, stress fluoro to judge the stability of the, lateral ligaments. This is just a guide for, what is torn. So sprain or physiologic laxity, you get 2.4 millimeters, and then 2 to 4 would be an isolated LCL injury, and then more than 4 would be complete tear of the posterolateral corner. And then, obviously, like on our fluoro, we don't have true measurements of millimeters. But from the MRI, you can measure like tibial width or femoral width. Could measure that on your fluoro, and then could kind of calibrate what that is. I don't know if that makes sense as a calculation. And then also just compare to the other side with amount of laxity on examination. All right, and so posterolateral corner injuries, a missed injury can be a failure for ACL and or PCL reconstruction. With the ACL, we see increased loads across the ACL graft in a posterolateral corner deficient knee for both varus and varus internal rotation loads. And then similar with the PCL, increased loads across that PCL graft. So if it's there, you don't treat it, that cruciate ligament reconstruction can fail. All right. Non-operative management with posterolateral corner injuries is generally maybe appropriate for grade 1 injuries, isolated grade 2 injuries. This will be a brace plus or minus a period of protected weight bearing 2 to 4 weeks, followed by progressive rehabilitation. And does anybody know like a thought for why non-operative treatment were not as successful for the lateral side versus on the medial side? We can often get that MCL to heal.
I mean, there's typically more motion on the lateral side of the knee than the medial side. So I imagine that that instability is going to contribute to it not healing.
Yeah. And then, with that, like if you think about the shape of the lateral versus medial compartment, like the medial side has more inherent bony stability, not quite as much motion. And so that ligament can heal, whereas the lateral side relies more on the ligaments and, may have just more motion across that when they're torn, so it doesn't predictably heal. All right. And then as we're thinking towards surgery, I think some questions are the timing of treatment, acute versus chronic, the location of injury, proximal distal, mid-substance, bony injury, soft tissue, the associated injuries, as well as knee alignment. And this study looking at repair versus reconstruction, I think this is something that will come up a lot. There's a number of studies, but this is, I think, one that like nicely presents it. But 35 patients had a primary repair for a posterolateral corner injury. 22 patients had a primary reconstruction, and found a significantly higher failure rate with primary repair versus reconstruction. So 37% versus 9%. For the repair failures, 14 out of 15 had an eventual successful reconstruction. So you don't really compromise anything, but still had that second reconstruction surgery. And then the final Leishman score was the same in both groups. So even if they went on to that, you could still get a good outcome, but a much higher rate with a primary repair versus reconstruction. This is another study that looked at repair versus reconstruction. So 10 patients had acute repair and then a staged reconstruction. And then 18 patients just had reconstruction from the start. The failure rate was higher in that acute repair group and about the same as that last study. So 40% versus 6, but no difference in final outcomes. And then this is good 2-part systematic review. And so again, repair had failure rate of 38%, and then posterolateral corner reconstruction with cruciate reconstruction had a 9% failure rate. So this is kind of across the board. This is that failure rate of like approaching 40% with an attempted repair, and then 9% with reconstruction. So for the surgical approach, there are, similar to the MCL, a lot of different ways to reconstruct it. I think this can be broken down with the main differences being fibular-based versus a combined tibiofibular-based reconstruction, and then the number of tunnels that you're placing. These are all different reconstruction techniques that have been described. Some of the main ones, and I think if you remember 3, would pick these 3. But so there's the Larson technique. And so this is a fibular-based reconstruction where you have a single point of fixation on the femur and then tunnel through the fibula and have this kind of triangle-based graft. And this will reconstruct the LCL, but then that rotational control may not be restored because you're not reproducing that popliteus tendon function. The Arciero technique. So this is similar with fixation at the LCL origin on the femur, tunnel through the fibula, and then instead of sewing this limb back on itself, they'll fix this at the popliteus point on the femur. So you have 2 points on the femur and then through a single point on the fibula. And this can give you better rotational control, but still just a fibular-based reconstruction. And then combined tibiofibular reconstruction, so the Laprade technique, like the anatomic posterolateral corner reconstruction. And so with this, you have 2 grafts. So one is reconstructing the LCL, and so fixed at the femur, and then tunnel through the fibular head, and then fixed at the fibula. And then your other is originating at the popliteus point on the femur, and then passing around posteriorly in an A to P tunnel on the tibia. And then you can also bring this tail around. You can see it sneaking around right here, and then that'll come through that A to P tunnel also. So here you see those 2 grafts going into that single A to P tunnel on the tibia. And then so this will reconstruct your LCL, will statically reconstruct the popliteus tendon, and then have the popliteal fibular ligament reconstruction as well. So that's reconstructing like all those points of the posterolateral corner, and will probably give you best stability to both varus stress and rotational control. Do those techniques make sense?
Do you choose amongst different techniques based on the injuries?
Yeah.
Yeah.
Yeah. And, if somebody has an isolated LCL, I don't think you need to, like if they have an intact popliteus, intact pop fib ligament, you don't need to reconstruct those. Like if their dial is negative and they just opened a varus, then I think this will be appropriate.
That's we did that one time.
Exactly, that's solving their problem, and that guy's doing great. But then if they're very rotational unstable, I'll favor the Leprod to restore that stability as well. And then so now going to part 2 of that systematic review. So looking at posterolateral corner reconstruction. So 90% success, 10% failure. And then in this, they weren't able to clearly say one of these was best. If you look at their outcome scores, about all the same, failure rates about the same across the board, but small sample size, unusual injury, et cetera. So my preferences, I would say scrutinize the pre-op imaging carefully and do a good exam in EUA. I'll try to, have this planned out ahead of time to know exactly what we're doing, and then finalize it based on the EUA at the time of surgery. If they have a bony avulsion, I think that can be repaired. Like if the fibular head is avulsed, can put that back down and that can heal. If it's soft tissue avulsion, I would favor reconstruction over repair. We know that those failure rates are higher with attempted repair. And then if able to repair something, I would still consider augmenting with reconstruction, as I think our failure rates will be lower, outcomes better, or outcomes the same, but avoiding repeat surgery. And then would, like Sasha was just saying, would reconstruct what's deficient. So full tibiofibular based reconstruction if complete injury, and then fibular based if no rotational instability. All right, so back to our case. Let's see. Any thoughts on our plan for this?
So for these combined injuries, like we just talked about, because addressing the PLC later could lead to problems with your ACL after surgery, you want to address them at the same time and probably relatively early, as opposed to a staged procedure or delaying approaching the PLC. And then because this is a combined injury, you could do the Leprod technique, which would address both.
Yeah, exactly. And then, Michael, any thoughts on what you would recommend for graft choice?
So I know hamstring or Achilles allograft are both sometimes used for this. I mean, so in this case, you're saying both for ACL as well as for your PLC?
Yeah, and with multi-legs, so if in an isolated ACL, I will really push people towards autograft. With a multi-leg, if they want allograft for everything, I think that's fine. Like it's a lot of surgery already, a lot to recover from. And this patient preferred allograft for his ACL. And then for the posterolateral corner, I'll use a split Achilles. And so you get can split the bone plug and have 2 separate bone plugs, split the tendon, and then be able to have bone plugs on the femoral side and then soft tissue on the fibula, and then going into that tibial-femoral tunnel. So these are just a couple arthroscopic images. So this is just looking in his lateral compartment, and you can see how much gapping there is with him in the figure 4 position. So clearly he's unstable. You shouldn't see a joint that wide open. And then did his ACL reconstruction. I'll start with doing the ACL reconstruction, fix on the femoral side, and then go do everything on the posterolateral corner and fix on the tibial side, and then finalize fixation on the posterolateral corner. And then these are just fluoro shots. So we have our button for the ACL fixation. I can see our ACL tunnel here. And then this is our LCL point on the femur. And then this is our popliteus point. And then this is our tunnel on the fibular head. And then this is that A to P tunnel on the tibia. And then he was able to get back to running by 6 months, and then back to He worked as a security guard and back to full work, and nice, stable, good knee.
Sorry, so you said you do the ACL first, fix the femoral side, then go to the posterolateral corner, and then fix the tibial side of the ACL, and then fix everything on the posterolateral corner?
Yeah, and so some people with these, they'll start with the posterolateral corner dissection. I like just getting everything done inside the joint first and then moving outside. So I'll place the tunnels, any meniscus cartilage work, and then you can place the graft and fix it on the femoral side, but leave it unfixed on the tibial side. So what you don't want is to like fix it and then you're manipulating the knee a lot, and then possibly, potentially causing an issue to your ACL. But so you can just have that there ready to go, and then you just tension and fix on the tibial side. And so I'll fix this, go do all of this, fix it on the femoral side, pass the grafts, and then fix on the tibial side, fix on the fibula, fix on this tibial point for the posterolateral corner. And then we'll talk about that a little bit on this next case too, that order and how to do it.
Okay. And one other question I had about repair for posterolateral corner. I feel like there was some talk about like if it's within 3 weeks, then acute repair can be better. But it sounds like from the data that you show, probably unless it's a bony avulsion, you should probably just reconstruct it regardless of acuity.
Yes, I think some people will still try an attempted repair, but those failure rates are going to be quite a bit higher.
Okay.
And one argument is that your eventual outcome will not be worse, and then you're avoiding tunnels and whatnot. But I think the literature across the board, it does show that you have a higher failure rate with just a repair of the posterolateral corner.
Got it. That makes sense.
And then so if you feel like you can repair things, you can repair plus reconstruct, and that's probably the better way to go. It'll be more surgery, but will probably be more reliable in decreasing that failure rate. All right. So case number 3, this is a 36-year-old. He was playing basketball, went up for a layup, and then like hyperextended his knee. And when he was coming down, he was transported to the emergency room, and then on exam had palpable pulse, toes warm, had some diffuse tingling, but otherwise intact and an obvious deformity. And this is how he showed up in the emergency room. And so, obvious knee dislocation. And then he was appropriately reduced. And let's see, Heather, what would you do initially?
So in initial workup, it sounds like he had good pulses, but you really want to make sure your vascular exam is really good, get ABIs, and if any concern, consider a CTA. Posterior slab splint, great. I've seen these treated initially with an X-Fix, either before or after MRI, often before, depending on how unstable it is. And obviously keep the patient overnight for monitoring.
Yeah, perfect. And so, you need the ABIs right away. And then these are ones that, especially if like you're the attending on call and you hear about this, like would make sure that they're staying for 24 hours. With a normal ABI, they should just have serial checks, because you can have, vascular injury that evolves over time. And he did have a CT angio that was obtained by the ED, no concern for vascular injury, had continued ABIs that were in the 0.9 to 1 range, tingling improved, and then was discharged home. And then with the question about the X-Fix, if they're reduced and stable, then I think they can be either braced or splinted. And then if they are, either malreduced, subluxed, or you can't hold a reduction, then would definitely place in an X-Fix. All right. So, and then I think, Heather, you mentioned MRI as our next step. So we can. And does anybody want to take a stab at just calling out, what we have here?
It looks like you have both a ACL and PCL. I didn't catch the collaterals though.
Oh. Not sure where that one went. Okay. And no, it's probably a little hard to go through on this, but he does have complete ACL tear, complete mid-substance versus proximal level of the PCL, grade 3 injury at the proximal MCL, and grade 3 tear of the LCL distally. And then it looks like a possible popliteus injury at the femoral attachment, and then a complete tear of the popliteofibular ligament. All right. And then, so we've talked about ACL, MCL, posterological corner. So talk a little bit about PCL. So obviously the primary function is to prevent posterior translation of the tibia. And then it's intra-articular extrasynovial, arthroscopically, we see that lining over it. And just adjacent to the medial femoral condyle cartilage. And on the tibial side, 1.5 centimeters distal. So the femoral insertion, just remember, like, it's kind of reversed from the ACL. So there's the anterolateral bundle and the posterior medial bundle. The anterolateral bundle is tighter in flexion. It's wider. It's a larger portion of the PCL. It's stiffer, higher load to failure, and it's the more isometric of the two. And then posterior medial bundle is tighter in extension. When we're doing a single bundle reconstruction, we're usually recreating the anterolateral bundle preferentially. And then on the tibia, those bundles are named by where they attach on the tibia. So anterolateral, and then you have the edge of the shelf, and then posterior medial over that edge. And then similar to the MCL, the PCL can heal non-surgically. So if you have an isolated grade 1 or grade 2 injury, plus or minus some grade 3 injuries, you can attempt treatment with a brace, have a posterior bolster to support the tibia from sagging back, and then have protected weight bearing 2 to 6 weeks, progressive quad strengthening, delayed hamstring loading, and then evaluation of their stability over time. Most patients, even high-level athletes, we can treat successfully with those lower grade PCL injuries. For surgical treatment, if they're symptomatic grade 2 or 3 chronic injuries, or combined injuries or larger bony avulsions, and then some people will treat an isolated grade 2 or 3 in a high-level athlete surgically. And then some of the controversies are in single versus double bundle reconstruction, and then how you fix this on the tibia. So, if you have, sorry, I don't know if these pictures are showing up strange on everybody else's screen. I apologize for that. But if you have a large fragment, this may be best treated with open reduction internal fixation. Sometimes you can do that through a posterior medial approach that's fairly safe, and other times you need a full-on direct posterior approach. And then a smaller fragment can do rehab if the knee is relatively stable, or if it's small fragment, unstable, just reconstruct the PCL. And then, the PCL, I think there's probably more to the double bundle thought with that than the ACL, just because of how big the ligament is. And, we're only recreating a small part of it. So the biomechanics, no question, the knees, the reconstruction is stronger with the double bundle, but there's no clear clinical evidence to show it as superior. This is just a meta-analysis, and no clinical evidence showing superiority of it if you look at laxity and Leishman scores, et cetera. And then with tibial fixation, kind of the two kind of primary thoughts. So one is a traditional technique where you have a transtibial tunnel. So you're just drilling all the way through, and then you have your tunnel on the femoral side, and then pulling that up and fixing it. You can also, some people will do like an open tibial inlay. The thing that's talked about a lot with the PCL is the killer turn. So you're bringing this here, and then this is turning like almost 90 degrees back the other way. And then so you can have abrasion of the graft at that aperture. And so this, you have those fibers taking off right here. And so you limit that, killer turn, which is thought to be a source of failure. We'll talk about, I think, one other way around it as we go through more, but this, no difference in reconstruction techniques. So, good outcome scores regardless of exactly how you do it. And then, oops, all right. So with this, we have our summary of injuries, and then I think kind of the important things to think about: timing of surgery, graft choices, order of operations, techniques for each, and then the order and position of fixation. So the decision making, I think it's still like a bit unclear. And I believe there's a study right now looking at early surgery versus rehab and delayed reconstruction in like a randomized setting. But this study, they looked at early surgery defined as less than 3 weeks from injury, and found that it was associated with higher Leishman scores and a higher percentage of excellent and good IKDC scores. So if you treat these multi-leg injuries earlier, may have better outcomes. Delayed surgery from other studies does have more risk of meniscus injury and cartilage injury. But then early surgery, you may have an increased risk of arthrofibrosis and stiffness. You also, if you're doing this arthroscopically, want to wait at least a little bit, especially for an injury like this where the capsule is completely disrupted, and have that capsular healing, or else you'll just extravasate into the leg, potentially have compartment syndrome as a result. And then, we were talking earlier about kind of order and getting to that concept of how and when you tension each of these. And this is just a recent biomechanical study, but looking at combined PCL, ACL, posterolateral corner, and how you, like the order for fixing them. And the yellow is PCL, then ACL, then posterolateral corner, and then blue, PCL, posterolateral corner, then ACL, and then posterolateral corner, ACL, PCL, ACL, posterolateral corner, or ACL, PCL, then posterolateral corner. So all the various combinations, and no order allowed for complete anatomic restoration of knee position and kinematics. But the best, especially in extension, was doing PCL, ACL, and then posterolateral corner. And that's kind of the order that I would favor. And the general idea is like restoring the central pivot of the knee, and then out from there. And then I would do like MCL after those. Does anybody know the position for fixation for the PCL?
Closer to 90 degrees.
Yeah.
Yeah.
Yeah. And then I think the best way to do this, you'll have it, so I'll fix the graft on the tibial side first for the PCL. And then you want to axially load the knee, have it in full extension, and pull the PCL graft tight. And that will help reduce the tibia. And then you flex the knee to 90 degrees and fix it at 90. So you reduce an extension, fix at 90. What I'll do is I'll pull the graft tight, flex it to 90, and then want to check the anterior medial tibia, because you should be sitting about 1 centimeter anterior to the medial femoral condyle. So you want to make sure your tibia is reduced, and then you fix your PCL, and that should eliminate. So now you have a reduced tibia, and then you eliminate the posterior translation. All right, and then our ACL will fix in either full extension or slight flexion with the tibia reduced and axially loaded. And then for the posterolateral corner, we'll fix, if doing the combined reconstruction, the LCL will be at 30 degrees and just with a gentle valgus stress. So you don't want to, do too much, and especially in the setting of an MCL injury where you could like overly gap open, you could kind of really close down the lateral joint by doing that. So you want the knee in like neutral to just slight valgus, and then fix the LCL. And then for the tibial fixation, so you'll pull that LCL limb through and that popliteus graft, and then have the knee at 60 degrees with neutral rotation. And then for the MCL, we'll fix at 30 degrees with a gentle varus stress on the knee. All right, so back to our plan here. Timing of surgery. Saw this patient just a few days after injury, and then gave him, a couple weeks just to, for hopeful capsular healing, and then, plan for reconstruction, and worked out at 20 days. So, targeting that early reconstruction. For something like this, I would encourage all allograft. This is going to be a lot of work on the knee, and then, taking hamstring, taking quad, patella tendon will add, both operative time and graft site morbidity. You could, incorporate autograft for any of these, but I think it'll be a lot more streamlined. And then this is one too where it helps to have, a good team, and have, somebody prepping all of these grafts on the back table. It can even do before the patient's in the room or asleep, start the prep for all of these. With a full knee dislocation like this, that you're going to be doing these. It's not going to be. He's already shown that it's not stable, so you can really start right away. And then for an isolated PCL, would consider a double bundle reconstruction. For something like this, I would plan for a single bundle. You've got a lot of tunnels that you're going to be placing, a lot of work on this knee, and probably doing the double bundle PCL may just be a little too much. All right, and then kind of my order for doing a case like this. So start intra-articular, and the PCL tibial tunnel has the most difficult visualization. And as soon as you start putting in tunnels, the fluid will leak out, and it'll be a little less visibility. So I would put that first. Then I'll place the ACL femoral tunnel, and then the ACL tibial tunnel. And then I'll do an outside in PCL femoral tunnel. And this one, you're looking right up at the front. Your visualization is, generally like very good at that point, like in the very front of the knee. And so no real issues with placing that. But if you put these tunnels in first and then go to put that tibial tunnel, it might be hard to really see in the back. And then I'll pass the PCL and fix on the tibial side, and then pass the ACL and fix on the femoral side. And so we have them fixed on one side, and then be able to move towards the rest of the knee. And then I'll go to the posterological corner next. First step will be exposing the peroneal nerve, any neurolysis, and then protecting that. I'll place the fibular tunnel, followed by that A to P tibial tunnel, and then go to the femoral side and place those tunnels. And then I'll fix the two grafts on the femoral side. I'll pass the LCL one through the fibula, and then have those two ready to go through the tibial side, but then leave those. Then I'll go to the MCL, expose the MCL, and then at least place sutures for fixation. Depending on how you're fixing it, you could put a suture anchor in at the medial epicondyle, or if you're placing sutures and then docking those down, but would have everything ready to go, but just not quite fixed yet. And then on the tibial side, so that traditional transtibial approach, you would have this long tibial tunnel. So here, this is just a guide, and fluoroscopically can show where we are, and then can place a pin to that point and then create the tunnel. And traditionally you could fix it down here at the aperture. This is an Achilles graft, and then the bone plug is here. We'll pull the bone plug all the way up and then place an interference screw at the aperture. And so here you can kind of get closer to potentially minimizing some of those effects of the killer return by having your graft, all the way up at the top here. So I think that's a nice way to do this. And so now we're fixed on the tibial side. And then, whoops, sorry. We have our button in place. So we have our ACL ready to go on the femoral side. And then we have our posterolateral corner reconstruction fixed on the femoral side, not quite fixed yet on the tibial side, and then have our A to P tunnel here, and then have our fibular tunnel here. And then so everything's fixed on one side, and then once you're going towards tensioning, you don't have to manipulate the knee so much. So you have everything at least stable to that point. All right, so then now we'll tension and do our final fixation. We'll do the PCL first, like we talked about. Full extension, pull the graft tight, flex up to 90, check reduction, and then fix on the femoral side. And then we'll fix just standard ACL on the tibial side. And then we'll fix LCL first, popliteus, to do our PCL, and then finalize the MCL repair last. Does that make sense? All right. And so this patient, he did well, but he really struggled with his range of motion. And that's, with a big injury like this, operating early on, that's going to be the biggest risk. Had a lysis of adhesions, manipulation under anesthesia, not uncommon for something like this. And then was able to get him like 0 to 135 in his EUA, good stable knee. Stable knee, and then improved range of motion after that second procedure. All right, and then just real quick in the last couple minutes. This patient, 30-year-old, left knee injury in car accident, pneumothorax, rib injuries. His knee felt unstable. He tried to use a brace, but it was uncomfortable. He is a big guy, 350 pounds, 6'3", has full range of motion, but has grade 3 posterior drawer, grade 3 opening to varus, opens an extension with no endpoint, and then a positive dial at 30 and 90. This is his imaging, and anybody have thoughts on his lateral especially?
Major posterior sag.
Yeah, so like he's sitting way posteriorly. And the other thing too is his slope is really flat. He has almost no posterior slope. Skip this. His MRI shows just complete PCL, posterolateral corner injury. And things to keep in mind with these patients. So he has varus standing alignment and a varus thrust with the ambulation, has that posterior sag and the decreased tibial slope. Standing alignment films. So his mechanical axis is passing medial to the medial joint line. And this is kind of just what he looks like on evaluation. So just remember with varus, the primary, double, triple varus. So standing varus, opening during gait due to incompetent lateral ligament structures, and then triple varus is the recurvatum with a varus thrust, with which this patient did have. And then this is one that you'll treat with an osteotomy. So this is a biplanar correction. And so correcting both the varus alignment and then adding in the slope, and can observe after that. Like 30 to 40% of patients will feel stable after that, not need further reconstruction. He's has not needed further reconstruction, at least yet, but we'll see. All right, so I think in summary, these are complex injuries and would encourage careful evaluation of imaging and the EUA to determine what structures to repair or reconstruct. I would favor reconstruction for the cruciates in the posterolateral corner, and repair versus reconstruction for the MCL. And then definitely plan ahead with regards to grafts, implants, order of operations. These are ones where, especially on that 4-ligament knee, where, write out a plan, have it on the wall, go through with the scrub tech, your operative team, to really, have everybody moving in the same direction and know, what those steps are going to be.